Another objective of the president's was that we had to make some considerable more investment in public health measures to reduce some really fundamental cost drivers we have in our system, including obesity, sedentary lifestyles, and smoking, and really do more to push our system from being a classic sick care system to one that's more oriented toward prevention and wellness. And this is a very serious issue for us. You may know that at current rates of weight gain, in particular, we estimate now that 80% of US adults will be overweight or obese by the year 2030. Or as Stephen Colbert has put it, 80% of US adults will be 160% of US adults in terms of total mass. But you know, this, no joke, this is a huge issue. We published work in Health Affairs suggesting that our medical costs alone attributable to obesity were close to $150 billion in 2008. It is clearly much more expensive to care for elderly individuals who are obese versus not obese, et cetera. So this is a very serious issue. And then we layer on our other issues. We still have 1 out of 5 US adults smoking, which is a lot better than 1 out of 2 US adults smoking, which was the case 30 or so years ago. But still, tobacco use remains our largest preventable cause of premature death. So we have a lot of work to do. What does the law do in that context? Again, you wouldn't give it an A rating for having done as much as could be done on prevention, but for the first time in the country, we will have a national health strategy that has to be articulated with arguably some goals attached to it, as well as some pathways attached to actually achieving it. We have a $15 billion new prevention fund set up through the Centers for Disease Control and Prevention. There are grants available for small businesses to put in place wellness programs in their for their employees, et cetera, et cetera. So again, not a ton, but at least a step down the road. And also, very interestingly, if you travel a lot in the US, within about a year, you will note that the national restaurant chains will have to disclose on their menus for the first time what the calorie content is of the things that they have on their menus. So if you go to the Outback Steakhouse, they will have to point out to you that the blooming onion has 100% of the daily minimum calorie requirements for a woman just inherent in the one dish. So except for the chains managed to get one exception written into the statute, which is that they don't have to say how many calories are in the daily special. So this is just a tip. Avoid the daily special because you can bet it's going to be the 4,000 calorie monster. Another principle of the president's was that the plan had to support the widespread use of health information technology, move more toward patient safety and quality. And in fact, it does that. And as many of you may know, we passed in our stimulus legislation that was enacted last year a new set of incentives that will go to physicians and hospitals if they can demonstrate so-called meaningful use of health information technology, particularly electronic health records, with the aim of getting the entire nation to nationwide use of electronic health records by 2014. Of course, almost every other major industry in the United States has automated itself around information decades ago. Healthcare, being as fragmented as it is, has not caught up. We came up with this novel idea to bribe people to install these systems, which is what we're now going to do through Medicare and Medicaid, and hopefully once we're supposed to finalize a regulation on what constitutes meaningful use within a few weeks, and that will allow these bonus payments to begin to flow forward under our Medicare and Medicaid programs to providers if they are demonstrating meaningful use starting with our next fiscal year. So there's a lot, again, in train, and if we can just keep at it, we probably will have nationwide health records or something close to that within several years, and therefore be able to take full advantage of the utility that electronic health records at their best give us to understand what's really going on in healthcare. To, first of all, to track what we actually do for patients, to create registries of patients so that we can understand, are we really doing what we need to do to manage our diabetes population as best as we can, et cetera. So I think that's another box that you check and you say, you know, it's all going to depend on the implementation, but at least in the statute and in the previous legislation under the stimulus law, we have done a great deal. The final principle of the president's was that we had to make all of this somehow pay for itself. We had to make the plan financially sound. It couldn't drive up the federal budget deficit. And we were going to recycle as much as possible some of the enormous sums that we spend on health care within the system. We were going to actually do some redistribution within the system and push some money around. And in fact, the plan does that. It has a series of features. It limits the rate of growth of payments to hospitals. It limits a whole set of payments we have called disproportionate share payments, which is the money that go to hospitals to help them care for the uninsured people. Instead, we'll use that money to give insurance to people, so they won't need the hospitals won't need these special payments anymore. All of this effort to sort of move money around in the system. If you look again at the way the Congressional Budget Office has rated that, they have concluded that if we do everything that is in law, in fact, at the end of 5 years, there will be actual deficit reduction coming out of the legislation. Now, it's not huge by our current standards. It's $140 billion or so. And of course, it deeply depends on whether we actually do what we put into law.